Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all yet another episode of 52 Weeks with Dr. Sanjay Kalra. Doctors, as you know that for last 10 weeks that we are doing our diabetes essentials program on tropical fever, as in this season that there are a lot of fever OPT cases, and these are the tropical fever months. For that purpose that we have started our tropical fever episodes, and today that we have another very interesting episode, diabetes and fever. So before moving forward, I would like to announce the last week winners: Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Rajiv Handa from Delhi, Dr. Sanjay Shiroha from Surat, Dr. Shivaji Patil from Kolhapur, Dr. Ravi Bhatt from Sirsi, Dr. Shashi Khare from Bhopal, Dr. Kaval Saluja from Mumbai, Dr. Ashwani Kumar from Kanpur, Dr. Ramesh Hegde from Bangalore, and Dr. Sanjeev Puri from Hoshiarpur. So I would like to thank all the doctors to take part in our quiz. Now, so today's topic is brought to you by Yo Zero Calorie Electrolyte Drink in Result Zero. Now, to enlighten on our today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. We've been together in this journey of learning, in this journey of exploration. And for the past 2 months or so, we've been talking about fever, different aspects of fever. Of course, the theme of our weekly meetings is diabetes essentials, and it's been going on now, it's the third year now. But we took a detour to talk about fever. But then, do fever and sugar have anything in common? I was thinking about this, and then I realized that when we go to a restaurant, when we go out to have dinner, sometimes we have sweet and sour soup. Sometimes we have sweet and hot chutneys. And these combinations of sweetness and heat, they are part and parcel of our cuisine. So we thought, is there a combination, is there a correlation between diabetes or sugar on one hand, glucose on one hand, and fever or heat on the other? And since we were thinking about this, we thought about all our experts, everybody who has talked to us over the past few months. And we thought, who is the sweetest one of them all? And who is the hottest one of them all? Or at least when he was in hostel in medical college, who was the hottest? Of course, not past tense, but present also. So, a warm welcome to Dr. Suneet Verma.
Namaskar, sir, and thank you for introducing again. And it's always a pleasure to see you and to listen to you and learn from you, sir.
The pleasure is ours, Dr. Suneet. It's mutual, but the nation wants to know, how are you able to manage this combination of hot and sweet together? And is the same combination operating at work as it is at home, or are they different combos?
So सब सीनियर्स ने सिखाया था, सब सीख रहे हैं सर आपसे.
Some seniors have sikhaaya. Okay, now that is a good way to go. Now I wonder, why is it that all our experts, Dr. Atul Dingda also says the same, and Dr. Suneet also says the same. And though I do try to change my questions, I try to create googlies in the questions. But warm welcome to everyone. Our topic for today is diabetes and fever. Dr. Suneet, you've been handling patients for so many years now, for 2 decades, and you have equal expertise in diabetes as well as in critical care in internal medicine. Would you like to talk about the various permutations, combinations that this hot and sweet combo brings to us?
Sir, definitely there are so many aspects of like whenever a patient of fever is coming to me or coming to any physician or to you, every time we try to find out is there any comorbid condition, and among those comorbid conditions the most important one is diabetes. Are you suffering from diabetes? Is he or she suffering from diabetes, or has she ever noticed any hyperglycemia in the past febrile illness? That becomes a very important and pertinent question. So definitely sugar has a very important role in a febrile illness. This can increase the chances of more infectivity also, because there's less responsiveness and prolonged treatment, prolonged need of antibiotics sometimes. So few things are definitely they get worsened in a patient with the pre-existing diabetes. A few infections are very pathognomic of diabetic patients. We really have to look into. And the response of treatment, drug to drug interactions, they actually have lots of importance in a patient who is suffering from diabetes and now coming with fever. So definitely there is a role.
Thanks, Dr. Suneet. And people are waiting eagerly to listen to you to talk about the various aspects of diabetes and fever. And many questions also coming from Dr. Jenny Ortega and others. But we'll wait for you to complete your slides before we take these clinical questions.
Sure, sir. So to begin with, sir, diabetes can is there something which can lead to fever as well as diabetes? Is there some illnesses? Is there some infection that can lead to fever as well as new onset diabetes or worsening of diabetes? Yes, there are. Acute pancreatitis is one of them. COVID-19, we all know now, is a very well known fact. A patient who suffered from COVID-19, and that was a febrile illness, definitely, and had led to new onset diabetes mellitus in a people who were not diabetic to begin with. Coxsackie virus B is very well known to cause diabetes as well as a febrile illness, rotavirus, mumps, cytomegalovirus, and there are enough number of other viruses probably which are some are known, some are not known, some have a proven factor, some are not proven. So, so if a patient is they are so linked, diabetes and fever. So most rare and important thing we have discussed in the beginning. So I won't say it's a very common if a person who is coming to us with a febrile illness has developed diabetes because of that febrile illness, but yes, definitely there is a relationship. Few infections are pathognomic of diabetes. Like if you can see those infections, you diagnose those infections, those kind of reasons for fever in a patient coming to you, then think of diabetes. What are those infections? That emphysematous pyelonephritis, malignant otitis externa, mucormycosis, Fournier's gangrene. So there are so many things which actually ask like these infections are very, very, very typical of diabetic patients. Fever can diabetes lead to some complication of diabetes can lead to fever. Yes, infected diabetic foot can lead to autonomic neuropathy. Patient have some problem with this senses of hot and cold that can also lead to fever. So this zone is so vast and varied that we will continue to see like patient is coming to us with fever, this diabetes can be reason and fever can be reason of diabetes. So anything. Symptoms are also very confusing in a patient. Patient is coming to us with a low grade fever. How will it present? Easy fatiguability. Doctor, I'm feeling very fatigued very soon. My muscles are paining. I have a leg cramps. I have a vague aches and pains. Patient may not even be knowing that he is running fever. Same presentation can be of uncontrolled diabetes. Patient is not knowing that he is suffering from diabetes. So symptoms can also be similar. Easy fatiguability, non-specific aches and pains. Can fever has what is the effect of influence of fever on diabetes? We all know if patient is suffering from diabetes and is coming with fever as of now, his hyperglycemia worsens. This is stress hyperglycemia is there. So, what are the atypical presentations? Something else is possible in diabetes is leukocytosis in decay. Patient is not having fever, but one can have a TLC count of 15, 16, 17,000, 18,000. And one can think of like he's suffering from sepsis when this may be leukocytosis because of decay. On the other hand, there can be a fever, there may not be any fever in a full florid sepsis in a grossly uncontrolled diabetic patient. Frail patient, grossly immunocompromised because of diabetes, he may not have a fever even in the setting of sepsis. So it's going to have a very mixed confusing clinical pictures in a diabetic patient, and this has a strong relationship with the febrile illness. What are the specific infections associated with therapy of diabetes? We all know SGLT2 inhibitors are very important and a boon in the treatment of diabetes. But is there something which can be, is there any complication that can be associated with SGLT2 inhibitors? Yes, urinary tract infection, or these are commonly associated with use of SGLT2 inhibitor in, especially in females. If a patient is not knowing the correct technique, is not following correct technique, if has not learned or has not been taught, they can have an infection at the site of injection of insulin injections that can lead to abscess formation and fever. More atypical things are lymphopenia with saxagliptin, anemia associated with metformin. They are the abnormalities which we see in a treatment of diabetes and very common drugs, and leading to some abnormalities in our clinical and biochemical parameters. Sensation of heat and shivering hypoglycemia. Patient can feel like probably I'm having fever. Actually, he is having recurrent hypoglycemic episodes, or she is having recurrent hypoglycemic episodes. Then she may feel like I feel very weak. At that time, I have a shivering. I feel like my face is flushing. So can have a feeling of fever. So then actually he's not, or she is not having fever. Immunity is lower in uncontrolled diabetes, we all know. And this actually can lead to excessive use or longer duration of use of antimicrobial therapy. This is well known. We see it day and night. In a diabetic patient, if a XYZ illness in an XYZ person takes maybe of the same age, same sex, and usually takes maybe 3 days to recover. Diabetic patient with uncontrolled diabetes may take 5 days or 6 days to recover. Patient with diabetes have a more chances of renal impairment during febrile illness, even in sepsis. This has a profound effect on the use of and choice of antibiotics and doses of antibiotics. We may not use other antibiotics dose which is actually needed. Use of concomitant therapy, they predisposes to drug-drug interactions, and drug-drug interaction is very, very important. What are they? We know commonly used drug, which should not actually be very common, quinolones, levofloxacin, ciprofloxacin, gedifloxacin. They all increases efficacy of sulfonylureas and ultimately lead to hypoglycemias. And this is pretty common. Patient has been given quinolones for URI, which is not good practice, in fact, which is unethical, but has been given and landing up in emergency in unconscious state because of hypoglycemia caused by drug-drug interactions of quinolones. Clarithromycin, tigecycline, ertapenem, they all can cause hypoglycemia. Fluconazole again can lead to increase in efficacy of sulfonylureas. This can also precipitate hypoglycemia. And then we really need to know about drug-drug interactions. Steroids can cause hyperglycemia, we know it very well. Older anti-HIV medicines like NRTI, zidovudine, stavudine, or protease inhibitor, indinavir, ritonavir, they all are associated with hyperglycemia. So we must know, when we are talking of a patient with febrile illness and diabetes together, so there have to have a very, very delicate balance of choice of antibiotics, choice of oral anti-diabetic drugs, or maybe insulin. So I have to be cautious, and we should tell patient, if patient is being treated on OPD basis, they should be aware of these drug interactions and possible side effects, like serious side effects like hypoglycemia. What are the impact of fever on diabetes management? So how we discuss is like effect on dietary therapy. We must encourage 3+3 meal pattern, 3 main meal and 3 snacks. Easily digestible food should be used in a sick and convalescent patient. This is a general rule. We must know the possible adverse effect which may limit the uses of oral anti-diabetic drug in sick patients. Very sick patient, use insulin. Critically ill patient, use insulin. We must know patient is having lots of nausea, vomiting because of febrile illness or maybe complications of febrile illness. We must avoid GLP-1 receptor analogs. Genitourinary infection, patient is coming with UTI, recurrent UTI, patient is on gliflozins, SGLT2 inhibitors, and we continue with those drugs. That is not going to work or ultimately lead to recurrence of infection or maybe persistence of infection for quite some time. Patient is coming with hypoglycemia, having recurrent hypoglycemia, but is continuing with sulfonylurea because he is suffering from diabetes, and now hypoglycemia is blamed to be because of fever. We have to be we have to be aware of use of sulfonylureas and how their drug-drug interaction is there in a febrile patient with diabetes. Insulin therapy should be masked in any sick patient with how sick the patient is. Does he need subcutaneous injections, long-acting, short-acting, ultra-short-acting? Is he eating or not eating? How much diet he's taking or she is taking or not able to take anything? It should be masked. As far as possible, short or ultra-short-acting insulin should be used pre-meal, and strict monitoring is important. Finally, a few words about tuberculosis and diabetes. We all know that diabetes increases the risk of tuberculosis as well as atypical pulmonary and non-pulmonary tuberculosis. Tuberculosis is also a risk factor for diabetes. How? Tuberculosis is an infection, and infection per se can lead to hyperglycemia, stress hyperglycemia, and there's a reason. Drug-drug interactions may be very important. How important? Rifampicin, they reduces efficacy of sulfonylurea and pioglitazone. They also reduces INH, reduces the efficacy of sulfonylurea, metformin, and pioglitazone. So blood sugar level control is deranged in a patient who is receiving ADT. On the other hand, rifampicin may increase the efficacy of metformin. So we may need to reduce the dose of metformin. We may need to increase the dose of sulfonylurea, pioglitazone. We may need to change doses. So we must be aware of these drug-drug interaction in tuberculosis. Very important cause of fever, psychosomatic causes. एग्जाम का बुखार जैसे होता है वैसे डायबिटीज का बुखार भी होता है. डायबिटीज डिस्ट्रेस, fever of diabetes, fever of insulin. Patient is fevering feverishly because he has been in a constant thought that he may need insulin. Doctor has advised insulin, has warned about insulin the previous visit, and sugar is not controlled. The next visit is due, and patient can have a fever of insulin. It's not fever actually. Culinary cruelty. That is one, like an appropriate word, I would say. Patient is coming, maybe young patient, 30 years, 35 years, 40 years of age, newly diagnosed diabetes. 4 or 5 family members are along with. Wife is there, sister is there, mother is there, father is there, brother is there. He is the person who is not taking care of his health and food. Look, doctor, we have stopped everything. Now he is not being given anything except ghee ka pani. So this kind of culinary cruelty is not there. I have to be aware of. Hyper-responsiveness is to be taken care of. We must counsel our patients and their family members regarding this thing also. Stigma is there, definitely is there with the diabetes, and patient is suffering from diabetes. He has diabetes. So patient himself is have a low esteem, low self-esteem. There is a definite social stigma associated with the name of diabetes. Now it's getting less. Unfortunately, a reason is because diabetes is practically in every third, fourth home now. So the stigma is getting low, but still there is a stigma, especially in the rural areas. So this was all regarding diabetes and fever, and very quickly we have some question. There's just a food for thought. What is the potential complication of high glucose level during fever in individuals with diabetes? Hypoglycemia, diabetic ketoacidosis, improved oral health, or increased insulin sensitivity. I repeat, what is the potential complication of high glucose level during fever in individuals with diabetes? Second question is, which type of diabetes is more prone to fluctuations in glucose level during fever or illness? Is it type 1, type 2, gestational or pre-diabetes? So we'll discuss later on. So, and this was all from presentation point of view. And now I request sir to take charge.
Thank you, Dr. Suneet. And you have actually shared a lot of food for thought. And since we began with this concept of hot and sweet, hot and sour cuisine, now suddenly everything seems so much simpler than before. But I'm reminded, Dr. Suneet, of a time when we were students. We were taught that he or she who knows syphilis knows medicine. Would it be true in today's world to say that he or she who knows diabetes knows medicine?
Absolutely right, sir. Diabetes is not an increase in blood sugar level. It's a multi-system disorder. It affects each and every system, right from hair to toe. Everything is affected by diabetes. So, who knows diabetes knows everything. I hardly knows 5% of diabetes. I'm still learning. So, I'm trying to learn from you, sir. Try to reach maybe 50% someday.
We learn from each other, and especially when you highlighted the fact that there are so many drug interactions which can cause hypo or hyperglycemia, that is equally important. So we have many questions lined up, Dr. Verma. From Jenny Ortega, we have this question. She has to handle a lady, 55-year-old lady with diabetes, who had a hemiarthroplasty done a week ago. Now she has infection at the surgical site with bleeding. So two questions. Which antibiotic do I choose? And secondly, the random glucose is 400. She is admitted in hospital. Do I straight away start insulin, or is there any second thought?
Second question to be answered first, sir. And there is no choice. Better is insulin infusion in the presence of severe infection and severe hypoglycemia, which can actually affect the clinical outcome, may worsen sepsis, and can lead to further complications. No confusion. Let's bring down the sugar levels to normal. Better is insulin infusion. Insulin infusion is more predictable, less chances of hypoglycemia if we keep on monitoring. And we can maintain a blood sugar level of around 150, 160, and maybe up to 180, not more than that. But will not try to maintain it less than 120 in any sick patient. So that gonna be a first target. Second, choice of antibiotic. Choice of antibiotic depends on so many things as of now in this case. But antibiotics she was on prior to admission, but she has definitely anything which is going to cover staphylococcus or gram positive, along with a mixed, like maybe gram negative. Both things should be. If the wound is dirty and stitches are bad, then probably we need more broad spectrum antibiotics. As of now, what practically I say, if everything is clean, so second or third generation cephalosporins, they will, third generation cephalosporin is good. They, along with gram positive coverage, maybe clindamycin in this case can be very useful.
And do beware, Dr. Jenna, that the renal function, hepatic function, cardiac function, all these have a role to play. But this I would also like to say, if a surgeon or an intensivist has admitted a patient because it is felt that intravenous antibiotic will be required, and the person has glucose, it would be almost criminal. I would not say 100%, but 99% of the time you would have to give insulin as well. If you are giving injectable antibiotic, injectable insulin will also be needed. And you cannot expect a patient to be well controlled on sulfonylurea metformin, while on the other side you are saying I'm going to give three broad spectrum antibiotics, all intravenous. So do both of them together. Another question from madam, that is LRTI, lower respiratory tract infection. in a person with diabetes, can we start antibiotics on the first day? So, Dr. Suneet, let's go stepwise. Lower respiratory tract infection, community acquired, hospital acquired. How long does it take to diagnose? How long
Actual
a
thing is,
history do we need? Yes.
I was about to come on the same point. Is first thing is it really LRTI? So very important thing is it really LRTI, or are we just by our intuition saying this is LRTI? So it's a very difficult to diagnose LRTI on a day one. Actually, very difficult. LRTI, one can suspect that patient is having uh, desaturation on day one. There are chest sign on auscultation, increased respiratory rate. We're clinically suspecting there is a pneumonia, but there may not be any patch visible on day one in X-ray. It's possible, as was there in COVID. Patient may not have something visible on X-ray on the day one or day two or day three. May have a visible pneumonia on maybe day 4, day 5, day 6, florid pneumonia, but which was not visible on day 1 or day 2. It's possible. But actually, it's become very tricky to say a patient is having LRTI on day 1. If we are strongly suspecting patient is having LRTI on day 1, that too bacterial, it's not COVID, then definitely we can start with antibiotic on day 1. Criteria for starting antibiotic is not LRTI or UTI or something else. It depends whether patient is how sick patient is. Vital signs are affected. Vital signs are very important. How much they are affected. So that becomes an important thing. Patient is having tachypnea. He or she is having desaturation. SpO2 is 89%, 90% young patient. We may start antibiotic on day 1 and we are not suspecting viral. Then we can start antibiotic. We can de-escalate any day. But a patient is coming in OPD, is coughing, and we are suspecting LRTI is too much. So then we really have to think, is it really LRTI or is coughing badly because of bronchoconstriction? Maybe reactive airways. Maybe only URI. Then probably I will not start antibiotic on day 1 and would like to wait.
So that I think Dr. Suneet is very well said. And the answer is do not rush to start anything on day 1. Unless maybe the patient has come with a history of 15 days of fever and cough, and then you get an X-ray done, the CRP is high, but you have to investigate. So I think what Dr. Suneet is saying in a single sentence is do not rush to label a person as having LRTI. Even if you have diagnosed LRTI, then if it is community acquired pneumonia, the treatment will be totally different. If it is hospital acquired, then of course it will be a totally different tag. In both of them, we need good glucose control if the person has diabetes. If you don't bring the glucose down to 140 to 180, you will not be able to manage the infection properly. Dr. Vinay Desai asks, if a patient comes with febrile illness, should I stop SGLT2 inhibitors? Secondly, if a person comes with febrile illness and the glucose levels are high, can I start SGLT2 inhibitor as part of glucose lowering therapy?
Patient is having febrile illness and it's sick, clinically sick. We stop all oral antidiabetic drug and switch over to insulin. More predictable, less chances of hyperglycemia, less hyperglycemia, less excursions of glucose level with pre-meal ultra short acting insulins. That is the rule. Specifically, SGLT2 inhibitors in fever, yes, if we are suspecting UTI, definitely we need to stop. In fact, any infection where we suspect patient is in sepsis, we should stop SGLT2 inhibitors. And second question was, can we start SGLT2 inhibitors? No. Let fever settle. There is no way that SGLT2 inhibitor is going to work in 2 days. Or we need to control blood sugar level with oral antidiabetic in 2 days in a febrile condition. That too with the SGLT2 inhibitors. So we can, that SGLT2 inhibitor initiation can wait. We need to control glucose level first. And best is in these cases is either ultra short acting, short acting sulfonylureas, maybe safer type if patient is not sick, or best is insulin therapy. Or we can use this glenites if a tall patient is very reluctant for the use of insulin.
Another soft drug to use is glipizide, a very economical drug, really economical, and it's not zero, but low chances of hypoglycemia. You can use them in elderly people. You can also use them in people with advanced kidney disease. A warm greetings to you, Dr. Smith, from Dr. Pradeep Rawal from Ujjain. He thanks you as well as Alin Zakat Saab for a very good talk. नितिन रुला जी पूछते हैं, I don't have fever, but I have daytime drowsiness with weakness, and I don't feel like going to work. Or Nitin, same thing happens to me also when I have to go to OPD.
Then you need
Body
to
aches.
take a break.
Yeah. So we need to find the reason actually. You need to go to a doctor and get the test done, Nitin. Otherwise, if you just keep on, sort of throwing arrows in the dark, you will not get anywhere. Speaking of a focused approach, our cricket team began very badly today. Very badly is an understatement, but now they've kind of made up for it. So currently, we are at 167 for 3, and we need 33 runs from 75 balls. The required run rate is 2.64, and hopefully we should be able to make that. Neha Gogikar ji asks if whatever you've said about diabetes and fever, do the same principles apply to pre-diabetes as well?
No, sir. Pre-diabetes is like of lesser intensity. Patient is not on oral anti-diabetic drugs, so I'm least bothered about drug-to-drug interactions of diabetes and fever in those patients. I am not concerned if blood sugar level rises to 130, 140 in a fasting in a pre-diabetic patient. In a febrile condition, during febrile condition, I may not start anything. I can wait for 3, 4 days, 5 days. It's not going to affect anything in a pre-diabetic state. And if there is a persistent hyperglycemia in a diabetic range in a pre-diabetic patient, we may tend to use short-acting insulin in those patients. So, not the same principles, because pre-diabetes is like having a lesser intensity of blood sugar, higher blood sugar levels, or of diabetes, I would say. So in those patients, same principle is not applied, but yes, they are not very much prone to or highly prone to severe infection, or they have a slightly more propensity as compared to people who are absolutely non-diabetic. But they are not those patients who are having a macrophage dysfunction because of grossly deranged blood sugar levels and having low immunity because of the reasons why diabetes causes low immunity. In those patients, probably I would like to treat them as a non-diabetic rather than diabetic with the eye on blood glucose levels. Some can have a stress hyperglycemia to the tune of like 300, 400 milligram percent with the onset of fever. Earlier, their blood sugar was 110 only, maybe 120 only fasting and 160 on the PP. But now, patient is with the onset of fever, patient is having a blood sugar level of maybe 300. I may have an eye on the blood glucose level rather than I'm worrying about the drug-to-drug interactions or complications of blood sugar level leading to infection in those patients.
Thanks. When we look at the Western guidelines, they tell us that in persons with pre-diabetes, we can consider pharmacotherapy, usually metformin. If the glucose levels are severely high, that means you're on the higher side, more towards diabetes than towards pre-diabetes. Also, if there is a high risk of ASCVD, or if there is established ASCVD, a specific indication for pioglitazone if the risk of stroke is high in a person with pre-diabetes, then pioglitazone is a better drug. From an Indian perspective, I'd like to talk about chronic infections. So when Dr. Suneet gave us this concept, he was talking about acute infections, acute fever. Now, supposing you have a person with pre-diabetes, that means the numbers say pre-diabetes, but the clinical picture is that of diabetes. Let's take an example. The person has a foot infection. Now, it's not diabetic foot because the person doesn't have diabetes, but it's a pre-diabetic foot. Occasionally, we get such patients. They're usually from the farming community. And the etiology is poor footwear compounded by inability or lack of willingness or lack of knowledge to change the footwear. So they continue with the bad footwear. Second etiology might be tuberculosis, what we see here, a chronic infection with pre-diabetes. Now, tuberculosis is said to be a pre-diabetic state actually, and the government of India has done a great job. Everyone who comes with tuberculosis has to get their glucose checked once at the beginning and once in between. It is part of the national TB program. A third concept is resistant or refractory or recurrent genital tract infection. Balanoposthitis in men, pruritus vulvae in women. And when we take a history, we find that the burden of these complications is quite huge. So in such patients, if the diabetes, if the glucose level is not reaching diabetic levels but is pre-diabetic, you might deem it useful to prescribe maybe metformin 250 milligram BD, 500 milligram SRHS, pioglitazone in case it's a very lean and thin patient with high risk of stroke. And then that also might help improve the glucose control and resolve the infection faster. But do that on a case-to-base basis. You can't sort of generalize for everybody. And like Dr. Suneet also said, if you have a couple of values of glucose 300, 400, don't rush to treat. You can wait for a day. So, Dr. Suneet, one question. Patient comes to you in ICU and glucose level is 300. How do we figure out whether it is stress hyperglycemia or it is pre-existing diabetes?
The patient is not giving any history of pre-existing diabetes, and HbA1c is a very good marker. You can find out HbA1c report is available in 1 to 2 hours. So one can always check it. First blood glucose level is 300. We started IV fluid, blood glucose level goes down. Patient was very anxious, patient was very apprehensive, or patient was in impending shock. So there are reasons for stress hyperglycemia, psychological as well as physical. So we have taken care of those things. Some fluid has been given, some reassurance has been given, and the second blood sugar, we are not wanting. This can be actually 180, 170, 160 without giving any insulin. If the blood sugar level after 1-2 hours of fluid resistation, or as deemed, some patients may not need fluid, some patients have a contraindication of fluid. After first like stabilization, continue to have high. Even if we don't have a values of HbA1c, we may use short-acting insulin in those. I am very comfortable if a patient is in ICU and is having a blood sugar level of this much high, then insulin infusion is very good. We can stop it anytime, and it's a very predictable. So very useful. If we don't have any monitoring measures, patient is in PHC level or CHC level, we don't have insulin pumps available with us. We don't have this much of means of monitoring. Then one can use subcutaneous insulin, or obviously they don't have ICU facilities. And then after initial stabilization, we can refer patient.
Thanks, Dr. Suneet. And these are really important points which tell us that when we are managing fever, we have to look at the glucose level as well. Don't be over aggressive, but at the same time, don't forget the glucose. You have to treat that, otherwise the infection won't get resolved. Nitin Nurlaje asks if it is, but you've already answered the question, is it mandatory to give antibiotics in cough? The answer is no. If there is an infection, then certainly we have to give. The infection has to be bacterial. Then we give an antibiotic. And anti-allergic alone will suffice. In many cases, yes, Nitin, but not in all, perhaps. Good evening from Dr. Vinayak Sharma. And two last questions, Dr. Suneet, if you allow. One is from Dr. Divya Nagpal. She says that my mummy has diabetes. She turned 47, so she is 47 years young, and she has had hot flashes for the past few months. This was treated with gabapentin, but now she feels hot at night and she can't sleep without AC. Now, Divya's question is, do we need to worry? That's her question.
Hot flashes is like at 47 is can be perimenopausal symptom or a post-menopausal symptom. We really need to look into menstrual history and need to figure it out and treat it if needed. Second is, at this age, we really need to rule out if something cardiac is going on. That actually depends on detailed history. Things will be clear from the history only. We may
Yeah.
not need ECG or echo for that thing. If clinically indicated, we can go for this. So
That's
things to
right.
worry or not actually depends on like what she is actually suffering from. Is it like hot faces are because of perimenopausal, menopausal symptoms, or we are thinking about something about cardiac? We really need to investigate. It actually depends on what actually she is suffering from. We may really need to find out more, dig out more from her.
Thank you, Dr. Suneet. And Divya, this is a condition where you actually need to take a good history. It can be an anxiety neurosis, it can be acute panic attack. It might be a hot flash, perimenopausal, so the history will tell us, especially if it is a surgical menopause. 47, the average age is 49 to 51 in India, but 47 is not too young also from a hot flash or menopause point of view. It can be cardiac as well, it can be an anginal equivalent, it can be hypoglycemia. So we actually need to dig into the history. It can also be restless leg syndrome. So if she is not able to sleep and her chief complaint is that my legs keep on moving, my legs feel hot, that is RLS, restless leg syndrome. Now, I'm not very sure about gabapentin, but I know that duloxetine can worsen RLS. So we have to take a history. It's not that you say that everybody has got either diabetic painful neuropathy or RLS and we will treat the same way. It doesn't work that way. You have to choose the drug accordingly. And if it is RLS, then maybe paroxetine. If it is menopause, paroxetine would be a better choice. If it is RLS, then pramipexole would be a better choice. Also, we are speaking here of primary conditions. Many times these conditions are secondary, and they are secondary to vitamin deficiency or to iron deficiency, or maybe to renal disease or hypothyroidism. So we need to do that. And here I would like to speak about iron therapy. Dr. Sunit, many times RLS is because of iron deficiency. Always we are not able to pick it up on a hemoglobin. So if you do a cursory examination, Haji jeep dikhaएं, you do not have pallor. HB is fine, it's 11.5, it's okay. Everybody in India has an HbA1c of 11. Uh, Sometimes we miss iron deficiency. So, sir, a single test that we would want to do to confirm iron deficiency.
Serum ferritin.
Serum ferritin. Thanks. So, first a history, Divya, and then the investigations. Don't go the other way around. Acute coronary syndrome patient, Love Humanity asks, is there a difference between ACE inhibitor and ARB? My patient is currently on lisinopril 10 milligram and is facing hypotension. Patient is also on bisoprolol 10 milligram, which is a high dose, and on nitrates.
Then really need to change. Need to lower down. Patient is having
We need to
symptomatic hypotension.
yeah.
Have to be
Mhm.
like we need to treat lower down therapy.
Yes. Check the pulse as well. That will tell you if you are over treating with bisoprolol, which I think is the case, and look for postural hypotension as well. And certainly we have to reduce. If you're not very sure what you can do, Love Humanity, you can make the dose twice a day. So let's say you're giving 10 milligram lisinopril. If you give 5 twice a day, that's not wrong. And what you can tell the patient is take 5 milligram once a day, and we always have the option of increasing. We have the option of taking the extra dose at night time. Same for beta blockers. Reduce to 5 milligram because 10 bisoprolol is a bit on the higher side. And reduce to 5 milligram. But if the patient feels uncomfortable, they can always add an extra tablet of 2.5 or 5 at night. Nehaji, if the glucose level is 600 milligram percent, then it is probably not pre-diabetes. It may be stress hyperglycemia, maybe, but we need a proper workup. Maybe patient has got steroid-induced hyperglycemia. This is a pre-diabetic patient, Dr. Sunit. Clinical setting is fever and glucose is 600.
So 600 is not same in pre-diabetic. Sir. So we really need to look into like we can always even if the HbA1c is in pre-diabetic range, HbA1c tells about the last 3 months average. The patient can have a stress hyperglycemia now, and probably in the last 1 month she is having increased blood sugar levels, or maybe using corticosteroid, or has been given some sort of corticosteroid recently, maybe for some joint pain. That can lead to precipitation of blood glucose level. Otherwise, other than this, if we leave all these causes, probably she is not pre-diabetic. It's a diabetes going on, and we were not aware.
In diabetes also, though I use this language in my OPD and it is not correct. When my patient comes in with an HbA1c of, let's say, 9 or 8.5 or 11, then my patient asks me, for how long have I had diabetes? And we say that the higher the A1C, the longer the duration of diabetes, which is actually incorrect. Some people will come in with a slow, insidious kind of worsening of glucose. Others come in with explosive, terrorist type of onset of diabetes. So if the beta cells conk off overnight because of a viral infection, because of a chemical insult, then the A1C may not even get time to rise. So all these permutations, combinations are there. One other thing, Dr. Sunit, let us say glucose is only 150, only 180, only 250. I'm specifying the only. But patient is sick. You do a urine ketone, that comes as large. Patient may not be in acidosis. Then how do you counsel your patient that, the glucose was giving you a wrong sense of security? Actually, the glucose had got converted to ketones. And now, since there is ketonuria and there is also fever, we need to fix that up. So, how frequent is this in your practice?
With the use of SGLT2 inhibitors, now this is being seen, especially in elderly people. Otherwise, the word only is yes, with the only 250, yes, it's there, but only 150, it's rare. So it's seen, sir. We see these kind of cases at least maybe 1-2 patients a month.
One of
Who says,
the
I have a sugar, no, डॉक्टर मेरी शुगर तो 200-250 पे रहती है, तो that ये तो sugar नहीं है. So we do see this. So because 200-250 is his perception or maybe his measurement on his luxury, maybe in a fasting state. He never measured. It may be 4:50 in the evening. He never measured it.
Mrs. Nagpal had menopause at 25, and now she is 47, which means 22 years of menopause. So here the diagnosis, Divya, is a premature ovarian insufficiency, and we should have treated with HRT up till the age of roughly 50, 51. But now starting after 22 years of menopause, that would be wrong because it doesn't make sense. So calcium, vitamin D, we treat the diabetes like you said, the angiography is fine. And probably this would this would be a symptom of diabetic painful neuropathy or maybe restless leg syndrome. So nutritional optimization, and if you've given gabapentin, that's fine. If it doesn't work, we try something else.
Vitamin B12 specifically, sir.
B12 specifically. Dr. Biswajit Haldar asks, dapagliflozin 10 and empagliflozin 25, can I interchange because of cost?
Any day.
H1C 6, if you can manage the cost, continue with 25 milligram EMPA, whatever you're taking. But if it's an issue, you can safely shift to DAPA 10 because there is a cost difference. Love Humanity says that he has a patient, age 29, young gentleman with an LDL of 167, not willing to walk, not willing to exercise. BP is normal, glucose is normal. So how do we calculate the risk and how do we decide whether to start statin or not?
So any value more than 160 in a patient who is not willing to have an active lifestyle in today's era, start with statin. So I know the age is not 40, age is definitely less than 40. But if patient is not willing to have active lifestyle, is not willing to walk, and probably is obese, probably I would say because you have not mentioned it. So we should, and the LDL value is 167. I would not like to wait for him to suffer from ACS or stroke before we actually start statin.
We start the statin. Maybe we can withhold the ezetimibe for a few months and see what the statin monotherapy does. If the pulse is high, it is more than 100, then Love Humanity says, can I start propranolol or any other beta blocker for an asymptomatic tachycardia?
Why the pulse is more than 100? Maybe try to look into cause. And if reasons may be many, patient can be anxious around the clock, may not be sleeping well, maybe taking some sort of drugs, maybe smoking more, maybe there may be enough number of reasons for high pulse rate. Sometimes we are not able to pinpoint what's the reason for high pulse rate, but there is no rationale of starting propranolol in these patients. Look for BP. If BP is on a higher side, let's start with a different type of beta blockers, if at all needed, and we can bring it down. Safer one can be more cardioselective kind of beta blockers. Metoprolol or other beta blockers, I would like to not use in a patient who is 29 years of age because of some effects, possible effects on sexual dysfunction. So cardioselective, more cardioselective can be used. If patient's BP is normal, what is normal is less than 128. I won't say 149. The blood pressure is less than 120/80 in this patient, and pulse rate is consistently high. Anxiety levels has been taken care of. His sleep pattern has been taken care of, and if still is not willing for any walk and any physical activity and pulse rate remains high, we can use other drugs which can be take care of pulse activity without affecting blood pressure. So it actually depends on overall clinical scenario of that patient rather than a single pulse rate. Ivabradine
Congratulations.
can be used.
Yeah. Congratulations to everybody because we've won the match, our opening match against Australia. We got 201 for 4 wickets in 41.2 overs, and we overhauled the target of 200. Good evening to Rahul Desai. Yeah, and I think if India has wrapped up the the one day in 41 overs, we should be able to wrap up our event in 53 minutes. It's already 53 minutes. But one last question from Ali Nazakaji. HbA1c was 10%. After 2 weeks, after 1 week, the HbA1c had come down to 7.2. All that the patient took in between was a gliptin and gliflozin combination. So in 1 week, from 10 to 7.2. Is it a lab error or can we explain from any biomedical perspective?
Most likely lab error, sir. HbA1c is average blood glucose level. It's a basically non-enzymatic glycation of hemoglobin in the past 3 months. Maximum effect is in the immediate sugar levels, but not in 2 weeks. 2 weeks is not possible. Probably there is some lab error.
And if you get a lot of fluctuation, then it would be a good idea, Aliji, to do a hemoglobin electrophoresis. Sometimes the labs don't pick it up. So a hemoglobin electrophoresis will root out hemoglobinopathy, and that will tell us whether we should get the HbA1cs done in future or not. We'd like to thank everybody for their questions. Nehaji ka question, we acknowledge what are the end stage of diabetes. That is a question. But we request you to continue listening to Diabetes Essentials, and that is what we speak about throughout this series. I'd like to thank Dr. Suneet for being with us and for having added that hot and sweet taste to Diabetes Essentials. I'd also like to thank Mr. Basu, who has spearheaded this entire series of events for the past 3 years now. And we have Karan with us. Karan, your comments about today's talk. So we have Karan Sharma with us, and on behalf of here Karan is Karan was celebrating India's victory.
Yes, indeed, sir. It was a very beautiful match indeed, and so was this session. We I before I come to the vote of thanks, sir said something about having this last 2 months as a small detour to our diabetes essentials. Sir, there's someone very well known who said that the way to our dreams will have many detours, and we share this dream of having a lot of um, places to create where you can where we get this opportunity to collaborate with Dr. Sanjay Kalra to have such beautiful sessions where we can address different medical difficulties, and he helps us to get on board specialists and eminent doctors like Dr. Suneet Verma and many more who come and share their knowledge. And this is one session where Dr. Suneet Verma beautifully you've covered about what how diabetes affects fever and how fever should be taken care for patients who are diabetic. Sir, beautiful speech and the way you covered the topic. Thank you so much for coming tonight to this session. And as always, Sanjay sir, it was pleasure to have you on this forum. From behalf of FDC, I wish everyone a very good evening and good night and Jai Hind. Thank you.
Jai Hind.
Thank you. Thank you, Jai Hind.